I've noted we have a huge agenda today, and I apologize for that, but a lot of things we need to cover. With that said, let's start with the roll call.
Senator Rocky Adams, Senator Chambers Armstrong, Senator Berg, Senator Carroll, Senator Douglas,
Present.
Senator Elkins,
Present.
Senator Funky Fromeyer,
Present.
Senator Nemes,
Present.
Senator Tishner,
Present.
Senator Wise,
Present.
Representative Bentley, Representative Bratcher, Representative Bray, Representative Burke,
Here.
Representative Callaway,
Present.
Representative Dotson, Representative Duvall,
Present.
Representative Frazier Gordon, Representative Justice, Representative Neighbors,
Here.
Representative Palumbo, Representative Raymer,
Here.
Representative Riley, Representative Rorks,
Here.
Representative Sharp,
Present.
Representative Weber, Representative Wilner, Representative Witten,
Here.
Co-Chair Mosier,
I'm here.
Chairman Meredith.
Present. We do have a quorum and fully constituted to do business. As you notice, we have a very full agenda. First item is approval of minutes. They were previously distributed. Is there a motion in favor of the minutes? Let's not be shy.
So moved.
Second.
Motion and a second. All those in favor say aye.
Aye.
Any opposition? All right, minutes approved. Again, we have a very lengthy agenda. We will be here the full 2 hours, but I assure you the train starts on time and we arrive at the station on time. So we will ask our presenters to be very prompt. Of course, it's mostly Commissioner Lee who's going to be talking today, so we'll ask her to keep the train moving as well. But in order to cover some very necessary business, we're going to have a change in the agenda. First, regarding excuse me, let me find my agenda. Let's work with the consideration of referred administrative regulations. Again, our responsibility is to review these. It's not to approve or disapprove. We can find them deficient if we find something we don't like. But to that end, I'm assuming everyone's had a chance to review. Are there any questions about any regulations or concerns that want to be expressed? Seeing none, we do have one person who's asked to speak on behalf of this, and this is Kaylee Meeks. Is that correct? Please come forward. If you would, turn the mic on, green light should come on, and identify yourself for the record.
I'm Caitlin Meckes. I'm the Director of Operations for the U.S. Hemp Roundtable. And I'm here today because we shared, so this regulation is regarding labeling and packaging for hemp-derived products. And the cabinet has been tasked with creating regulations for hemp products such as Delta 8. Our organization, the U.S. Hemp Roundtable, represents over 80 companies in the hemp industry, and we're partially based here in Kentucky. I spoke at the Administrative Regulations Subcommittee meeting in November alongside Jim Higdon, who has a hemp company called Cornbread Hemp out of Louisville. At that meeting, the members of this body encouraged the cabinet to work with us on our recommendations, and they did. So I'm just here to express our sincere appreciation to the cabinet for listening to our requests and working with us collaboratively to make changes. Obviously, we've not seen the updated regulation, but we look forward to reviewing that when it is made public. Thank you.
Thank you, and appreciate the comments. Any other questions or concerns? Of course, a motion, right? There being none, is there a motion to move forward the regulations? Excuse me, we have to accept an amendment on 902 KAR 45:190E, which is the hemp-derived cannabinoid products. So first, I'd entertain a motion on this particular regulation. Motion and a second. All those in favor say aye.
Aye.
Any opposition? All right, thank you. Then the balance of the proposed administrative regulations, is there a motion to accept? Motion and a second. All those in favor say aye.
Aye.
Any opposition? By like sign. There being none, then we move forward. Next item we're going to listen to or hear from is the legislative hearing on the temporary assistance for needy families block grant. And I don't know who's going to testify on that, but ask them to come forward. Obviously caught them by surprise. And you thought you were going to snooze in the back of the room for another hour and a half.
Good afternoon. My name's Laura Began, Staff Assistant with the Department for Community-Based Services.
Good afternoon. Todd Trapp, Director with the Division of Family Support and Community-Based Services.
You surprised me a little bit because I did anticipate presenting on House Joint Resolution 39, which covers a lot of the same information, but I'll be glad to go over it here.
Thank you. Please proceed.
Thank you. So the TANF block grant is before you, the preliminary state plan for it. The Department for Community-Based Services administers 5 federal block grants. These are block grants that are federally funded, and we submit state plans for them every 1, 2, or 3 years, depending on the type of block grant that it is. These block grants fund social services, community services, emergency utility assistance, child care, and temporary assistance for needy or low-income families, which is before you now. So we are required to submit a state plan to the federal government that says how we are going to spend the funds, meeting the rules of the block grant. Each of those 5 block grants have specific rules and requirements. And KRS Chapter 45 requires us to submit a preliminary state plan for the legislature's review before submitting that federal plan. So this is something that we do regularly for your review, approval, and comment, if you have any, before submitting the federal plan to the federal government and making any changes that you all would like. And this is in the public comment period as well, so we're open to public comments before submitting that federal plan. Now, the changes in this specific TANF state plan, for those watching or in the audience, the plan is accessible on the LRC committee webpage under meeting materials, and we've highlighted the differences between this state plan and the one submitted previously. Almost all of these changes are the result of administrative regulation changes that have been made in the past year that were reviewed and approved by the General Assembly as well. And many of them address the benefits cliff, which we'll be getting into a little bit later today, but we are happy to take any questions that you have. The one change that was not an administrative regulation was to extend the an extension, a very small extension on TANF recertifications that we are requesting for the beginning of 2024, just to allow our caseworkers to catch up on some of the past due tasks. And actually, I did want to give a large shout out to our staff who are doing an amazing job catching up on past due tasks. They've really made amazing progress. So we'll be happy to take any questions. Thank you.
Thank you. Excellent presentation. Any questions or comments? There being none, is there a motion to approve the grant?
So moved.
Motion by Co-Chair Moser. Is there a second? Second. This one requires a voice vote, so all those in favor vote aye.
Aye.
Any opposition? Like sign. All right. Thank you.
Thank you.
Thank you. Now getting back to our formal agenda. I'm sure you all have noticed this meeting has been devoted exclusively to Medicaid and a lot to cover. And appreciate the work that Commissioner Lee has and her folks have done on this. You've got a wealth of information, and I'm making the assumption that everybody has done their homework and reviewed this information in order to keep us on track. I hope we can limit our questions to the very most necessary ones and keep them concise. Commissioner, if you would please proceed. Come forward. While she's coming forward, I just want to make an editorial comment. You know, last session we passed Senate Bill 48, which is the reorg bill for the Cabinet for Health and Family Services, and one of the recommendations that came out of that was to obviously split our committee of Health and Family Services and Health Services and Family and Children's Services, but also eliminate the standing committee on Medicaid oversight and let that be the responsibility of this committee. That's one of the reasons today we're devoting this agenda solely to Medicaid, but in our current task force dealing with reviewing the cabinet as well, I think we've come to the realization that it's probably a mistake for us to eliminate Medicaid oversight because, as you folks well know, this next budget is going to be $16-17 billion, which we'll hear more of later. And just to be able to devote one meeting to it during the interim is probably not sufficient. And we're probably going to have the recommendation to come back with that as a standing committee. So with that, Commissioner, if you would, please identify yourself for the record and please proceed.
Good afternoon. I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
Good afternoon. You'll hear from me again as well, Laura Began with the Department for Community-Based Services.
My name is Andrea Day. I'm the Director for the Division of Child Care within DCBS.
Commissioner, I want to thank you again for the great job you've done with the information you provided to us. There's a wealth of information here. Again, I hope the committee members have reviewed it, and if not, they need to do so after this meeting today. You can prepare for the next session. But to that end, I've devoted about 25 minutes to this particular agenda item, so please feel proceed.
And I'll turn it over to my colleagues at DCBS for the beginning of this, and then I will provide some Medicaid information in the beginning.
Yes, so good afternoon, and thank you again. So we're here right now to talk about House Joint Resolution 39, a resolution passed in this past session that really took a deep look at the benefits cliff and how the cabinet can take steps to address it. The General Assembly, the Cabinet, and many of our partners have been discussing the benefits cliff for the past year or two, but I don't think we've presented to this committee specifically. So the benefits cliff is the sudden, unexpected decrease in public benefits that can occur with a small increase in earnings. So employers across the state and the country have occasionally been told by their employees that they can't accept a small raise or a small increase in hours for fear of losing their public assistance benefits. So that is the benefits cliff issue. It is a major workforce issue. And again, we've worked with you all and many partners on different steps that we could take to address the benefits cliff. So this resolution required 4 different steps and reports to be compiled and submitted by November 1. I invited Director Andrea Day here as well to talk about childcare because childcare has been a very large focus of the benefits cliff. Again, I mentioned what benefits cliff is, but usually that revolves around Medicaid, childcare, or sometimes SNAP, food assistance that individuals and their households are afraid of losing. So childcare, I think it's largely agreed, is one of, if not the largest benefits cliff that households encounter.
Yes, and just for the committee's overall education, the Child Care Assistance Program does assist low-income working families to secure child care, and we pay for part, if not all, of that tuition cost for a family out of federal funds. And as of November of this year, we have served 32,217 unique children, which represents about 18,800 families, and that's at more than 1,900 programs across the state. This slide shows you the average cost of child care in a licensed type 1 or type 2 setting, and those are our larger centers. 90% of the child care providers across the state are these larger center-based programs. Registered and certified providers make up 10%, which is our in-home providers, and we have been trying to incentivize more and more small business owners to think about certified and registered providers because that's a small business that they can operate from their home, and it makes a big impact, especially in our rural areas and our child care deserts. Based on this slide, you can see that the average statewide cost for licensed child care is about $750 per child who attends full day. And like Laura said, child care is one of the steepest benefits cliff a family will face. If a family has 2 children and they become ineligible for CCAP, it's $1,500 a month that they're going to have to come up with the next day. You know, essentially, that's $18,000 a year to a family's household budget. And most of our families, working or not, can afford that steep of an increase. So the next slide, please. Here are some of the changes that we've made to CCAP over the last 2 years. We initially were paying providers, eligibility was at 160% of the federal poverty guideline. We upped that to 200% of the federal poverty guideline, and then we increased it again to 85% of the state median income. So that made a lot more families eligible to qualify for this program. That increased about 4,400 children, 3,000 families became eligible with those increases. We also started in March of 2022 the transitional child care program, which the state pays 50% of a family's child care rate for 6 months to help them adjust to that cost of not being eligible for CCAP any longer. Again, to try to let them stair step, if you will, to absorb that into their household budget. And then we also increased the provider reimbursement rates. Prior to COVID, we were paying at the 40th percentile of the market rate survey. That means that's what the market was able to support in childcare. It doesn't even consider cost of quality and the true cost of care. We upped that to the 80th percentile so that providers were being reimbursed at a higher rate, so that would lead to continuity of service and also allow them to sustain their businesses over the past few years.
So the next report that was submitted, the next section of House Joint Resolution 39, was to create an awareness and education outreach campaign around the Earned Income Tax Credit and free tax filing services among public assistance recipients. The resolution noted that the Kentucky Chamber has said that it's estimated that 80% of eligible Kentuckians with low to moderate income are claiming their earned income, less than 80%. So there's still a lot of room for individuals who are eligible for it to claim it. And there has been an estimated $230 million unrealized in tax credits annually because of individuals not taking advantage of this credit. So the cabinet developed a work group over the interim to focus on this issue and discuss outreach and awareness and make plans around it. The work group consisted of DCBS, folks from our Office of Technology, Metro United Way of Kentucky, the Kentucky Chamber, and the Department of Revenue. Our first step was, fortunately, we do have pretty much all of the public assistance programs in Connect, which allows us to reach them all simultaneously. We took advantage of that in creating a notice that would go to all households who had claimed earned income, all public assistance recipients that are in that system. So our first step was to create a notice, just making them aware of that. We sent that out on October 1st, just that there may be tax credits that they're eligible for. That went to 530,000 households in October. And then second, we created another notice that would include information on the EITC, free tax filing services, and VITA sites across the state to help them with those tax services. 211 phone line, which connects individuals with resources in their community, and Connect. We put all information about all of those resources on our second notice that will go out to all public assistance participating households in 2024, and those will continue going out every 6 months. So they'll receive notice of this during tax season and then out of tax season as well. We still have plans for the future. We just had a great meeting with the IRS in the last week or two about Earned Income Tax Awareness Day in January and our plans to help support that. So that is continuing work, but at least we have already undertaken some measures. The next report and section of the resolution was required a thorough review of public assistance programs to look at where we could take steps to transition folks out of public assistance programs and help address the benefits cliff. So this required a very thorough review of all of our programs. Most public assistance programs are administered by the Department for Community-Based Services, But in the past, we've seen legislation that included Medicaid and WIC kind of grouped into the public assistance category. So those are administered by the Department for Public Health and, of course, the Department for Medicaid Services. So we collaborated in this review as well. SNAP, of course, is formerly known as food stamps and is the primary, one of the nation's most important programs aimed at specifically reducing food insecurity. SNAP, of course, provides nutritional support, especially to individuals who are elderly or disabled. In the essence of being aware of time, I won't get into details about the program itself. I'm sure you're aware, but it does already include steps that help individuals as they earn income. It's already structured so that as individuals increase their income, the SNAP assistance they receive decreases gradually, so that's kind of already factored in. And there's already income deductions and exclusions for earned income and out-of-pocket child care expenses. So that's already not counting against SNAP recipients, so it doesn't hurt their eligibility. The Kentucky Transitional Assistance Program is our state assistance program funded with TANF. So here's where it connects to the TANF block grant. Again, both of these programs, the benefits are 100% federally funded. With KTAP, we made a lot of changes in the past year. The program hadn't been updated in a very long time. You may remember discussions about those administrative regulations, but we included a lot of changes that helped address the benefits cliff, such as increasing the resource limit. So that's the amount of money or assets that a household is allowed to have while they're participating in the program. So that could be money in the bank. And of course, we know that as individuals, if they have more money in the bank, they can adapt more and transition away from public assistance programs easier. So we did that. We increased the earned income disregards and income deductions. Therefore, it wouldn't hurt against them. They're not going to lose their KTAP assistance because of an increase in earned income.
And related to the Medicaid program, Medicaid is a program that covers health care for low-income individuals in the state. We currently have 1.6 million individuals enrolled in the Medicaid program. Over 660,000 children are enrolled in Medicaid and the Kentucky Children's Health Insurance Program, or KCHIP. That is over half of the children in this state. The state currently has 1.1 million children under the age of 18. We have 660,000 children approximately in the Department for Medicaid Services. And it's some things that we have done to address the benefit cliff has been in the making for many years. For example, we have our state-based exchange called Connect. When individuals do not qualify for Medicaid because they make too much money, they can go to the Connect website and enroll in a qualified health care plan. They can also receive an advance payment tax credit, or APTC, that helps with those premiums. During the period of unwinding in which we are emerging from the public health emergency, you will see that we are seeing an increase in the number of individuals getting a plan on Connect and a qualified health plan, and we'll have some more information on that later to come. Another thing that we have done, federal rules required states to cover pregnant women up to 200, to cover pregnant women and postpartum coverage. We currently cover, when individuals who deliver children, we give them 12 months postpartum coverage. Prior to this year, it was only 60 days. So there's a certain subset of women who now remain eligible for Medicaid after they deliver their child. We also cover children and pregnant women up to 218% of the federal poverty level through our CHIP program. So women are covered in Medicaid up to 185% of the federal poverty level. For those women who fall outside of that, we can cover those women in CHIP and give them up to 218% of the federal poverty level and let them enroll in Medicaid. Of course, our Medicaid expansion covers adults age 18 to 64 up to 138% of the federal poverty level. We also have a transitional medical assistance benefit that covers parents who would otherwise lose eligibility because their income is in excess. They do have approximately 12 months of transitional medical assistance to help them transition off of Medicaid. Some other things that we could do to implement policies to help with the benefit cliff would be a basic health plan. This would be a plan that would bridge between Medicaid and a qualified health plan to give individuals a little bit more time to adjust to moving from Medicaid to a commercial-like plan. There is also a Medicaid buy-in, which allows individuals basically to pay a premium and remain in the Medicaid program. And we've talked a lot about the federal poverty level, or FPL. I just wanted to show the chart to let you know what, for example, 138% of the federal poverty level is for individuals in the state of Kentucky. As you could see, a family of four can make $41,400 a year and qualify for Medicaid. And because Medicaid is based on this poverty scale, the difference between being eligible for Medicaid and not eligible for Medicaid is $1. $1. So $41,401 would make someone ineligible for Medicaid. And this is gross. This is not net. This is pre-tax. So again, just giving a little bit of information about what the federal poverty level is so we know those income levels for the individuals who qualify for our program.
The last report and section of the resolution was about the benefits cliff calculator. We were required to use a benefits cliff calculator tool with public assistance recipients. And this work has been in the works for some time also. We've been working with KY Stats. They have developed a family resource simulator, so we've worked with them to make it more user-friendly and available to individuals. And all of our public assistance case managers have been trained in the use of the tool, and they do use it with individuals and households as they make decisions regarding workforce and public assistance programs. Many of our partners also use this tool, such as Goodwill Industries, Community Action, and United Way. So it is out there. It's really become much more user-friendly, and we appreciate the partnership. We are still in the works of connecting it to Connect, having the systems talk to each other so that individuals don't have to put in all their information multiple times. So that is still in progress, but we really look forward to what that will do for public assistance program recipients.
And with that, we'd be happy to take any questions you may have.
Thank you, excellent report. And I just have a couple of questions. Doing the tax credit, I appreciate the work you've done on that. That could be a great resource, but how will we be able to measure the effectiveness of that outreach? How will we know if we've been successful in reaching those people and they've taken advantage of it?
I think we can definitely look at the number of individuals who enroll in the advanced payment tax credit. When an individual leaves Medicaid, they have a couple of choices. First, they can enroll in a plan on Connect if they qualify. If they are employed and their employer offers health insurance, they could get insurance that way, or they become uninsured. So the way we measure the success is the number of uninsured individuals that we have in the state. Currently, the state of Kentucky is below the national average on rate of uninsured. We're at about 6% right now. I think nationally it's about 9%.
I look forward to the information sometime next year as to how successful we've been, but appreciate that outreach. But to use a statement that I never had heard before, that was a great meeting with the IRS. I've never heard it before.
I don't think that was me.
Other question I have is your child care assistance program. Again, great work. I appreciate the changes that you've made there. But do you see this as kind of a Band-Aid at this point? Is there something we're going to have to do even broader in the future to address this obvious problem?
It's something that we're looking at sustaining all that we have started, but yes, to continue to fund them at the same levels. There would need to be more.
Well, the reason I asked the question, I don't know of any subject that we haven't paid more attention to there in this interim than this, and we certainly all want to work together to try to address this. It's imperative for the success of our state.
Yes, sir.
Co-Chair Moser, you have questions?
Thank you, Mr. Chairman, and thank you so much for this report, and thank you for your work on this. This is something that we've had conversations about for a long time, and I'm very excited to see that we're using the benefit cliff calculator, for everyone here, I think we all know the purpose, but to make sure that folks who are kind of in and out of that eligibility period, to create some stability in their life and to allow them to move ahead in their career, and to accept raises and to accept promotions, and really work their way off of government benefits. And so I'm very pleased, and I know it's relatively new. Are you able to see what sort of uptake we are seeing, or any sort of participation numbers?
You know, I don't have that information, but I can probably get that from KY Stats. So I will touch base with them and follow up with you. Thank you.
Yeah, I would just be interested to see what sort of outreach and how we're accomplishing our goals. So,
Yes, ma'am.
and then of course any recommendations that you all have in terms of what we can do with, especially the child care assistance program. I know that we need to find a way to support our providers and encourage folks to become providers. So anything that you have in terms of recommendations would be appreciated. Thank you.
Yes, ma'am.
Last question on this topic is Senator Douglas.
Thank you very much, Mr. Chairman. Thank you also very much for the presentation. It really was pretty informative. I just have one quick question. For those persons who are involved with the Supplemental Nutrition Assistance Program, are we keeping track of the numbers of the percentage of persons or the total number of persons who are receiving this, who either decrease their need for this program or come off of this program each year? And is there any way I can get that number versus those going on?
I'm sure that we do track it. We have our director here as well to speak to it. Would you like to? Yeah.
Hello, Todd Trapp, Director of Division of Family Support. We track monthly participation in SNAP, and what that means is number of households currently receiving as well as number of individuals. And so we track that month to month, so we can certainly show an increase or decrease in the program. And I wanted to make sure I caught your question. You were asking if we know whether they've transitioned to employment. Is that what you were asking? Or if they continue to need the program, I think?
Correct. If they continue to participate in the program at its greatest amount, or they're reducing their dependence on the program.
Okay.
So as their income increases, their dependence is reduced because as a function of their benefit level being reduced. Does that make sense? So
No. May I clarify my question, Mr. Chair?
No, certainly.
Thank you. No. We understand that part. I'm just looking at raw numbers. Part of what our job is to make sure that the program is doing. You all administer the program, but our job is to make sure that the program is doing what it is set out to do. And if our numbers are continually climbing, I am very concerned that the program is not doing what it's meant to do. Because part of it is to give people relief, put them in a position, and since our birth rate is going down, we should at some point get to where that number starts coming down. And so I'm just looking at raw numbers as to each year how many people are either coming off the program or reducing their need for the program versus those who are actively going on to the program.
certainly we can get you the last 12 months of numbers if you think that would be helpful. The trend of participation in SNAP, I think, very much matches the economic trends. I can say that. And we've seen that over time. And the purpose of the program itself is to supplement a household's ability to buy nutritious food. And so I think there's no doubt that the program is a success in those terms.
Well, I appreciate that. Again, I'm sorry, Mr. Chair. We understand what the purpose of the program is. I'm not arguing the purpose of the program. What I'm simply asking are for the raw numbers so that we get a feel for that as us people here on the committee, and we can present to our constituents in our districts who are questioning why the number keeps going up. We need to know what numbers to be able to talk to our taxpayers, who not just here in the Commonwealth but across this country, about what they're funding and what that funding's going for, and how that program is working, the results of the program. We can understand what it's for.
Yes,
I'm
sir.
just asking for raw numbers, if I may.
Yes, sir. We'll get those numbers to you. I will just take special note that actually a very large percentage of SNAP recipients are the elderly. Just in response to your comment regarding children, but we'll get that information to you definitely.
Well, the children, actually the comment regarding children came from there, not from here. I'll just ask for the raw numbers.
Yes, sir.
Thank you.
Thank you.
Interesting comment you just made about SNAP elderly. What percentage are elderly? Do you know?
So we, it was part of House Bill 7, I think. Is that right?
Yes, sir.
We implemented it effective October 1st of this year, an elderly simplified application program. And what that does is provides some relaxed verification requirements. We still verify income and household size and everything. But because of the nature of those elderly households, they don't have that many changes in their situation. And so we're able to provide them an extended certification period and somewhat relaxed verification requirements. And we only have to do an in-person interview once every 3 years. So as part of that implementation, we converted every household who met those criteria, which is where all the adults in the household are elderly or disabled, and there's no earned income in the household. When we converted, and we did a mass conversion on October 1st, when we converted those households, it was about 40% of the SNAP caseload at the time. And so I think that's indicative of how many elderly and disabled, use the SNAP program to help meet their needs.
And again, that's households that are entirely elderly or disabled as well, not households that have multiple generations in them.
Good. Thank you. Good information. Appreciate the presentation. We'll move on to the next agenda item, which is a report on
Thank you.
Joint Resolution 54. And there's actually two parts of this resolution. One that deals with reimbursement for outpatient pediatric therapy, and secondly, the possibility of using the area deprivation index as a payment methodology for disadvantaged areas. Have a very lengthy report that Milliman did for us. Great information. Again, I encourage you, if you haven't looked at that report, to do so. But with that, please proceed.
Lisa Lee, Commissioner for the Department for Medicaid Services.
Good afternoon, chairs and committee members. I'm Paul Houchins. I'm a principal and consulting actuary with Milliman.
Good afternoon. My name is Catherine Wentworth.
I don't believe your mic's on. Try it again. Green light on.
There we go.
My apologies. Thank you, chairs and members of the committee. My name is Catherine Wentworth. I am also a consultant with Milliman and a co-author of the report.
So Senate Joint Resolution 54 required the Department for Medicaid Services to just study the area deprivation index related to social risk and health-related needs as it relates to Medicaid payment models. So we thought this was a very important report and also somewhat complex and technical. So we looked to our actuarial contract with Milliman and asked them if they could help us with this report, and they did. Again, has some really good information in here related to how health-related social needs impact an individual's health. Also relates to social determinants of health. And one thing that this report does not really address is the impact that our hospital reimbursement improvement program may be having on payments, particularly in rural areas. As you know, we have a hospital reimbursement improvement program that was expanded to also include outpatient services in hospitals that allows hospitals to receive supplemental payments that equal the average commercial rate that insurance companies would pay for them. This report also doesn't really address the federally qualified healthcare centers or rural healthcare clinics around the state that receive they receive a prospective payment system rate, which means they receive 100% of cost for doing their services. So it doesn't really address those two specific payment models, but it does have some very good information in the report. And with that, I'm going to turn it over to my colleagues at Milliman to tell you about the summary of the report.
Commissioner, just before you proceed, I just want the committee members to understand the motivation for this particular resolution. You folks very well know that in spite of the Affordable Care Act passed a decade ago, where we do have more people with coverage now, that we're not improving the health of our population significantly. Some improvement, but not significant. And we still have several healthcare deserts throughout the state, most notably in rural areas, in our inner cities. And this is an attempt to try to redirect resources to the most disadvantaged population, and that's its intent. So with that, please proceed.
So to start with, we wanted to give the committee an overview of the Area Deprivation Index. The Area Deprivation Index has been around for a few decades. It's been maintained and updated by researchers at the University of Wisconsin-Madison. It is a publicly available tool. As you can see on the slide, there's a link to it, and there's a nice mapping tool where you can look at the nation, you can look at a state, you can drill into a particular city. And so the Area Deprivation Index allows for the ranking of a neighborhood based on its socioeconomic disadvantage. And so what's going into that? That includes the community's income, education, employment, and housing quality levels. And when we say neighborhood, this tool is looking at what's called a census block group. And so these are neighborhoods generally from 600 to 3,000 people large, so you can get pretty detailed. And so this index provides a score for each neighborhood ranging from 1 to 100, with 1 being the least disadvantaged and 100 being the most disadvantaged. For the purposes of kind of presenting the results of this index, we've bucketed all the neighborhoods into 10 deciles. So the first decile represents neighborhoods with a score of 1 to 10, and then the 10th decile represents neighborhoods with a score of 91 to 100. And so from the mapping feature that's available on the website, you can see the dark red neighborhoods. Those would be the most disadvantaged neighborhoods according to this index. There's a high density of those in eastern Kentucky. I don't think that surprises anyone. But as you noted in your remarks, there's also pockets of disadvantaged neighborhoods across the state. And you can see that if you look at like Lexington and Louisville, yes, there's a large concentration of blue neighborhoods or dark blue neighborhoods representing kind of the least advantaged parts of the state. But you also have pockets of the most disadvantaged neighborhoods in those cities if you were to drill into those metropolitan areas in a little more detail. So if we go to the next slide, so how we incorporated this into our analysis is that we received the Medicaid eligibility file that has member level information, including their zip code, and we mapped basically the area deprivation score onto each member's kind of eligibility record using their zip code information. And then we kind of merged the eligibility data with the Medicaid managed care encounter data to basically summarize historical claims experience from calendar year 2022 based on these 10 kind of area deprivation index deciles. And for this analysis, can kind of do everything, but what we wanted to focus on some of the healthcare services that you would typically think would be influenced by provider access levels. And so we chose to focus on physical exams, emergency room visits, office visits, and dental services. And so this first chart is looking at physical exam utilization, and we have shown it for your child population, which is the orange line, the gray line, which is your kind of non-disabled adults, and then the blue line is your expansion population. And so we look at healthcare utilization using a measure called utilization per thousand. And so what this is we're essentially saying for a group of 1,000 people, how many healthcare services would they incur in a 12-month period? And so if we look at the chart, in the orange line, we have 900 visits, physical exam visits for the children living in the first decile, so the least disadvantaged neighborhoods. And as we kind of move to the right on the chart, you can see as the neighborhood's kind of socioeconomic disadvantage worsens, we see a pretty steady decline in those visits as we go from 1 to 10, and that's true for all the populations. So this definitely indicates there is a correlation between kind of the area deprivation index scores and this physical exam utilization. If we go to the next slide, we look at the same statistics for emergency room utilization as well as dental utilization for children. So for emergency room utilization, sometimes we see people use the emergency room for non-emergent services, and that could be the case if there's a issue with primary care access. And so what we see with the emergency room utilization is that we have the lowest utilization in the neighborhoods with the lowest area deprivation index scores. And then as we get to about the decile 6 or 7, we see it kind of level out. So again, we see kind of the patterns that we would maybe intuitively expect based on the area deprivation scores and what we know about how kind of healthcare utilization patterns are influenced by access. And then with the dental utilization, just focus on the child population, and we split it between dental cleanings, which is obviously a preventive service, and then level 2 through 4 services, so non-preventive services such as getting your cavities filled. And so with the dental cleanings, we see pretty steady utilization for the first 7 deciles, but then kind of in the areas that are the most disadvantaged in the state, we do see a pretty material decline in dental cleaning utilization. But then the reverse is true for the non-preventive services, where you see kind of the utilization steadily increase as the deprivation score increases across the neighborhoods. So getting into some of the policy options at a high level, so the legislation did ask for us to dig into Maine, Massachusetts, Washington, and Hawaii, as well as look at a national landscape. So we did want to briefly touch upon those 4 states. So I'm not going to read the table verbatim, but the states are all doing a little bit different things. Some states are adjusting provider reimbursement directly, and other states are directly adjusting the capitation payment that the state is making to the managed care plans based on social risk factors. So today in Kentucky, there is what's called risk adjustment, where the state adjusts its managed care payments to its health plans based on clinical risk factors. This is a budget neutral process. It doesn't change the overall money that's going into the Medicaid delivery system. And so what Massachusetts, Washington, and Hawaii have done, in addition to the clinical risk factors, they've also added an element of social risk into their risk adjustment. I think it's important to remember that these states they're not adding more money, they're just kind of changing how the money is allocated amongst the different populations and health plans based on both clinical risk as well as social risk. So now I'll turn to Catherine, who's going to go over some of the observations from the national landscape.
Thank you. So one of the things that we wanted to talk about in regards to our analysis was the recommendation to evaluate policy options related to the ADI scores of different areas was discussed in terms of making changes to the state's Medicaid fee schedule. And as Paul just talked about on the previous page, a number of the states that were specifically referenced in the resolution didn't actually do it that way. So this is a bit of a unique idea in terms of thinking about changes to the fee schedule. Instead, for the most part, those changes from a payment perspective were made in terms of changes to the way managed care plans were paid, or in the way the states covered particular services or maybe added certain services that were hoped to address health-related social needs. We wanted to make sure that we also drew attention to some of the other prevalent themes that are being seen in how states are addressing health-related social needs in their Medicaid programs. And there's a few examples here provided. In thinking about it in relation to the Area Deprivation Index, as was discussed previously, the Area Deprivation Index methodology looks at factors such as income, education, employment, and housing quality. So lack of access to healthcare may be one reason that an area scored high in terms of their ADI score, but that may not be the only reason, or it may not be the reason at all. And so as states are taking a look at how they address the health-related social needs in their areas of most highest deprivation areas, they may be looking at other strategies. Some examples that we see here tend to be things like using the Medicaid benefit package in order to pay for certain supportive housing services, additional care management services. Could be things related to, for instance, if it's a food desert area, maybe individuals would get prescriptions for healthy fruits and vegetables that would be paid for as part of their Medicaid benefit. Another thing that is really important to consider, and I think we can go ahead and go to the next page with this, there are a wide variety of payment options that states can use as they're thinking about how to drive reimbursement to providers as well as to new services or new supportive activities that their managed care plans have to do. Again, we're not going to go through all the details of these. They're walked through in quite a bit of detail in the report. But one thing that is important to consider, particularly for Kentucky, is that the vast majority of your Medicaid program is operated through a managed care delivery system. That will drive some of how you are restricted and how you can get dollars to healthcare providers. The state's Medicaid program, once it has made the decision to operate through managed care, has to pay providers through that managed care system, with some very small exceptions. For instance, the commissioner mentioned the payments to federally qualified health centers. All other payments for managed care services have to run through the plan. So even if the desire is to change the fee schedule, those things would have to happen through the managed care contract and through the federal authorities that are required in order to make those changes through the managed care contract. So this is the last slide that we have here, and it's really meant to be just a visual. Again, you'll have copies of these, but a big important thing for Kentucky to consider are what are your specific goals. If your goal is really about improving access to services, then driving those reimbursement changes to providers may be the best way to do so. If the goal is really to try to impact some of those health-related social needs at an individual level, then there may be a desire to either marry that with a strategy around additional covered services, or perhaps look at some of these other opportunities that are more directed at the services specifically to individuals versus the payment amounts for providers. And we're happy to answer any questions.
Well, Commissioner Lee, with all this wealth of information you have, what's your assessment of where we are and where we need to be?
Well, I look at you sometimes and think, is that a rhetorical question to you? Is that? But I think I think that it's a very, very complex topic. We all know that there are a variety of factors that go into an individual's health. Reimbursement is one of those, because I always say the Medicaid program was created for our Medicaid members. We cannot take care of our members if we don't take care of our providers. And how do we do that? We know that COVID has placed a burden on our providers. We know that the cost of health care continues to increase. And I was asked at one point, what do I think the core benefits or the core services are in Medicaid? Every one of our services are core services. Everything that we do is leading to improving the lives of those we served. Senator Meredith, you mentioned, we're not making that many strides. We currently have moved from 43rd to 41st in America's health rankings. We were 47th, went to 43rd, and now we were 41st. We know that there was a report that was produced that said we are number one in access to behavioral health care for adults. However, we're right in the middle for children. We know that we have a lot of work to do. Again, it's very complex, and one of these models is not an answer. I think it's a variety of options that we need to look at, and we also need to focus on what do we really want to improve. Where do we want to focus our quality measures? What do we want to look at, and what measures do we actually want to improve? And I don't think that's something that we're going to be able to do in a week, a month, or a year.
Well, I think the push-pull on this is, and you've already made mention to it, access to care, versus the social determinants of health. We all know that social determinants of health account for 60 to 70% of healthcare problems in our community. So, which comes first, the chicken or the egg? From my perspective, it needs to be access to primary care. And you've heard me quote the statistic before, 40% of our population is rural Kentucky. But only 17% of our primary care physicians are in rural Kentucky. If we have access to primary care services in rural communities, I think that improves the health of our population and reduces the Medicaid expenditure, which in turn can provide funds to address those social determinants of health. So again, we've always said, well, we need to address social determinants of health. There's no money for there. There is money. It's within the Medicaid program, but we're going to have to redistribute some resources to get where we need to be. And same with those urban deserts. The fact that Louisville's getting a hospital in the West End for the first time in 50 years, anybody's even talked about that area. I look for significant improvement in the health of that population because we made that investment in those resources. And I think we need to make a comparable investment in rural areas as well to get them primary care. And it lifts up the tide for everyone else. So to do nothing is the worst thing that we can do. I understand the complexity of it, but sometimes we get lost in complexity of it. It's much simpler than what it appears. And again, that's based on my 30 years as a hospital CEO. If you will pay physicians and other healthcare providers adequately, equitably, equal to their urban counterparts, you will get those professionals there, even in the period of manpower shortages. But we're not doing this. This is nothing new. It's been around for decades. So we need to have some strategy to move this thing forward. And again, that's why I think something based on the area deprivation index, which pushes the most needed resources in the most needed communities, helps solve that problem. So where do we go from here?
We work together to figure out how we solve this issue.
Okay, y'all heard her, okay? Senator Douglas?
Thank you, Mr. Chairman. I just have a couple of short questions. I had several, but some of them were answered, and I think you gave a really good presentation. I thank you so very much for the information that was provided. I have two questions. One is, if we take a look in the areas that have a lower area deprivation index, do we see a lower rate of utilization among our Medicaid population than in those with higher ADI? Or are they equal? Or do we look at that at all? Because we're always talking about the programs and we're talking about the social determinants. And the only way to really look at the social determinants is to take a look at a similar population in different environments.
Yeah, I think there's a lot of room for additional follow-up studies based on maybe some of the details that the committee would like to see from this analysis.
Yeah, we'd like to see it. We love being educated. Since we're all working together to move this ball forward, we really would. At least I would, and I think my fellow members in the General Assembly would like to see that as well. And I guess the only just the broad question, and anyone can answer this. Do we really think we can spend our way out of this situation without making changes in the program? Since our history hasn't particularly said we could, I just wonder if there's anyone who has any comments about that.
Yes.
Well,
again, it goes back to which is going to come first, the chicken or the eggs. 60-70% of our problems are based on social determinants. Mm-hmm. If we address those and improve the health of our population, it saves money from the Medicaid program. So it may take some initial investments, Senator Douglas, but long term, it should pay for itself and then generate a significant return on investment. But we've got to make that commitment, which we've never done. Could we continue with the next part of the report? I'm sorry, Senator Berger, you have a question. I didn't see you over there.
Thank you, Chairman. And also, Mr. Chairman, thank you for your belief in medicine, because clearly you're expressing a belief that access to health care actually does improve lives, and I appreciate that very much. I have two questions. The first is going to be the easier one, and it's on this slide 5. This area deprivation index, and it really goes to a whole nother committee that I'm on. But could you show me in northern Kentucky on this area deprivation index slide where the areas of concern are?
Yeah, so on the website, we could drill into
Down lower, but it's basically, so it's not the nice blue tip up top. It's sort of the red, yellowish blue tip below it, below
I
it.
think even if we zoomed into the Cincinnati area, you'd likely see some red
You would find
neighborhoods.
some. All right. And then my second question is going to be, I don't think you're going to have an answer to it, but I would love to have an answer to it. Is there any data that shows that people who do not access health care over the course of their lives die younger, have more pain, are less productive? I mean, do we have data that shows that access to a primary care physician improves the quality of patients' lives? Or is that an assumption?
I mean, I think there's a fair amount of data that suggests that
There
higher
is.
income population has longer lifespans relative
Thank you,
to a
thank you,
lower
thank
income
you.
population.
Okay, that answers it. Then my last question, my last statement. If you go, I think it's forward from here, looking at different ways that you can adjust and what different states have done. And there was a slide that talked about Oregon and how their MCOs are basically really closely involved in housing at this point, much more so than basically any other state in the country, as far as I understand. And the reason I find that very interesting is because the woman who has run the National Association of Physician Legislators since I've been elected comes from Oregon. And she is very, very aware of the association between basic needs like housing, food, and healthcare outcomes. And somehow in that state, they have been able to translate that data into actual action in a way that is actually having an impact. She's an amazing, Dr. Steiner, she's an amazing physician legislator in Oregon who's doing awesome work. So I just wanted to point that out to people.
Thanks, Senator Berg. Good, let's continue so we can make sure we stay on track here.
Bringing in reinforcements.
Good afternoon. My name is Veronica Judy Cecil, Senior Deputy Commissioner for the Kentucky Department for Medicaid Services.
Steve Bechtel, the Chief Financial Officer for the Department for Medicaid Services.
Good reinforcements. Good job, Commissioner.
So Section 3 of House Joint Resolution 54 required the department to examine the reimbursement rates for outpatient pediatric therapy, including pediatric audiology services, behavioral health therapy, occupational therapy, physical therapy, and speech therapy, and develop a proposal for increasing those reimbursements rates and submit a report with their findings by July the 15th of 2023. And I'm very happy to report that we did meet that deadline of July 15th of 2023. I am not happy to report that the report that we submitted was inaccurate. We submitted the report, and I can tell you why it was inaccurate. Is we have three different fee schedules, one for speech therapy, one for physical therapy, and one for occupational therapy. Procedure codes span those three disciplines. So when you run a report in Medicaid, if you run it just on those procedure codes, you're going to pull in duplicates. So that's what happened. We gave the report to the committee. We gave the report to our Therapy Technical Advisory Committee. And when you look at the report page by page, it really doesn't stand out. But when you lay those charts next to each other, one of our therapy providers said, hey, wait a minute, something's wrong. And so we went back, we reran the report. We do have a corrected report that will be sent to the committee very soon. We're double checking that report, have all confidence that it is correct based on the new criteria with generating that report.
Just like Meatloaf said, 2 out of 3 ain't bad. So.
Correct. So, based on our report, and I'm going to go through some other very specific information in a minute, but our data takeaways is that the total amount we paid to providers for pediatric claims was greater than the amount we paid for adults in audiology, occupational therapy, and speech therapy. It was less than the amount paid to providers for adult claims in behavioral health and physical therapy. Compared to our fee-for-service versus managed care, the majority of claims were billed through our managed care organizations. About 90% of our population is served by our managed care organizations, so that definitely comports with what we're seeing. The minority of units billed and total amount paid to providers for adult claims were less than those in the fee-for-service. That is because, we're more fee-for-service adults received more therapy claims than our managed care population because our fee-for-service population consists of long-term care individuals and individuals in our 1915C home and community-based waivers.
May I ask a quick question? Again, great report, good information, but in the comparison, what are we looking at Tennessee, Alabama, and North Carolina? Why aren't we looking at Ohio, Illinois, Missouri, West Virginia? Since
as far as rates are concerned?
Yeah, because that's who we compete for manpower, and that's what drives this issue as much as anything.
Well, I have a slide on that, Senator Meredith.
Thank you. Appreciate that.
So our audiology reimbursement is, I think it's really important to understand how we reimburse our providers. So for all of these specific provider types, the physical therapy, which I'll probably refer to as PT, occupational therapy, OT, and speech therapy, we pay the lesser of the provider's usual and customary charge. We do pay based on a Kentucky-specific Medicare fee schedule. We pay PT, OT, and speech therapist 63.75% of that fee schedule. Assistants get 37.5%. There are a variety of codes on each fee schedule. Some of them do span disciplines. Again, we have 48 codes for hearing aids. One code's reimbursed at 65% of billed charges, and that is a dispensing fee. Our behavioral health therapy includes treatment for behavioral health therapy, substance use disorder, co-occurring mental health and substance use disorders, and our behavioral health therapy can be provided by individual providers, community health centers, all those you see listed on the slide here, and it can include a variety of therapies. Our behavioral health therapy reimbursement, it has and this isn't unique just to behavioral health reimbursement. This is all reimbursements in the Medicaid program. According to CMS, we have to have a sound methodology, and some of those methodologies can be a relative value scale, taking into account physicians' time and effort, a fixed upper payment, either Medicaid or commercial payments, or use of a state-specific internal process based on market conditions, cost of care, other factors. And Medicaid, the Kentucky Medicaid, bases most of our reimbursements on Medicare fee schedule, the Kentucky-specific Medicare fee schedule. Behavioral health reimbursement rates are different based on provider types. Again, this is true for most services in Kentucky. Medicaid. Our behavioral health therapy all behavioral health therapy was expanded in 2014. Prior to 2014, we've covered very, very limited behavioral health therapy or behavioral health services for any population enrolled in Medicaid, except for children, because we have an early periodic screening, diagnosis, and treatment benefit, which is EPSDT, which states that a child under the age of 21 should receive any service, whether or not it's covered under a state plan. And the state plan, the Medicaid state plan, outlines every single service that the state covers with limitations. It also outlines reimbursement methodology and the eligibility processes and who qualifies for Medicaid. A very complex and very complete, comprehensive state plan.
Sorry to interrupt you again, but just one clarification on the statement you made about we pay according to the Medicare fee schedule.
Mm-hmm.
But the MCOs are not contractually obligated to pay according to that. Is that correct?
That is correct. Managed care organizations can contract. They do contract with providers, and some of them may contract based on the Medicaid's fee-for-service fee schedule. They may outline other provisions in their contract, and that is a contract between that provider and the MCO. So when we do talk about rates, you are correct, Senator Meredith, that this is for our fee-for-service population, and the MCOs may or may not follow this specific methodology.
Do you know how often they do follow that methodology? And
I don't know exactly how often or which ones. We do have 6 managed care organizations. I'm not sure of the reimbursement, and they could do a variety of reimbursement methodology depending on their contract with the provider and what they negotiate.
so it's a recommendation from the department to use the Medicare fee schedule, but they're not obligated to use as a percentage of the Medicare fee schedule.
Our contract does not specify how they the reimbursement methodology that they have to have with their providers, their enrolled providers.
And we really don't have an effective way of monitoring what they are reimbursing providers. Is that fair? It's not a criticism, just is that fair?
Well, we do have encounter claims. An encounter claim is a claim that comes from the MCO. We don't monitor to see the reimbursement rate. We do monitor to make sure that that is a correct claim and that they are providing services that are aligned with their state plan amendment and what they are required to provide.
Okay. Thank you.
We have a total of 98 codes on our behavioral health fee schedule, and approximately 30 of those codes are related to therapy. And here we get to where we compare with other states related to behavioral health therapy. So you can see the blue line indicates where Kentucky is. This came from a national survey. You can see it was from healthaffairs.org, but this is reimbursement for all Medicaid psychiatric services. It's not specific to therapies. States with the highest reimbursement are listed here along with the lowest, and some of those reimbursement rates vary, of course, by geographic cost of living and state-to-state rate-setting processes, where we design our program based on Medicare when possible. They may have a different methodology for determining their rates. Occupational therapy, I think this is, again, important. Independent providers were added as billable to the Department for Medicaid Services in 2014. So prior to 2014, all therapy services, PT, OT, and speech, were covered in an outpatient hospital setting only. Because of that EPSDT benefit, during the time prior to 2014, the department enrolled independent providers as a provider type. Each provider in Medicaid has its own individual provider type. We enrolled them as a provider type for EPSDT only, so we had therapists who are billing for therapy for children outside of our state plan alignment with the outpatient hospital services. The rate for the EPSDT providers was developed at $85.05 flat rate, one procedure code. So we have several different procedure codes. For example, on our occupational therapy, and a lot of this is just general information. Our occupational therapy reimbursement, we have 2 different fee schedules, one for a facility, one for non-facility. There are 64 codes on our fee schedule. So again, 64 codes related to occupational therapy, and then we have these providers that are EPSDT providers who are billing for occupational therapy, one procedure code, so we don't exactly know what they're billing, how many units they're billing, if they're spending 15 minutes with a member or they're spending an hour with a member. And again, we have the 2 different facility codes. I bring this up, the two fee schedules, because we used to have 2 fee schedules for behavioral health, and we combined those fee schedules and made sure that when we moved facility to non-facility and combined them, that we used the highest rate on those fee schedules. There's not a lot of difference between those two fee schedules, but that is one option to combine those fee schedules for occupational therapy. And here's a reimbursement comparison for Indiana, Texas, Alabama, North Carolina. Sometimes it's a little bit difficult to find specific reimbursement fee schedules for states. Not all of them are easy to find online, or they may not list them. And as you can see, Kentucky's comparison to those other states, sometimes it's not always a fair comparison, because you'll see the dark shaded areas are procedure codes that other states do not cover. Kentucky covers a wide variety of those codes. You can see, for example, You can see, for example, almost in the middle of the page, the evaluation, the OT evaluation. We are higher than Indiana and Alabama. We're close to North Carolina, but Texas is higher with their evaluation code. So this is where we compare to other states. Physical therapy, a lot of this information mirrors the occupational therapy. So we can go through the physical therapy reimbursement. Again, we have two different fee schedules. There's not a significant difference between the non-facility and facility fee schedule. Again, comparison of our rates with some other states where we were able to pull those codes. Again, you can see almost, a little bit up from the bottom, the evaluation code. We pay $61.14, a little bit higher than Indiana, lower than the rest of the states. But again, those areas shaded in dark are codes that are not covered in those states. Speech therapy, same thing. And again, you'll notice that all of these were added as billable in July of 2014. We do have some annual limits for each of these categories, but they can be exceeded in the event that a member meets medical necessity. Again, we have two fee schedules for speech therapy facility, non-facility, not a very big significant difference in some of the rates. Again, comparison across states, you'll see again the same trend that we cover some procedure codes that the other states do not cover. One code, there's only one code where Medicaid in Kentucky is higher than the rest of them, somewhat comparable to Indiana. But again, I don't think it's somewhat, when we look at our other states, that it's a fair comparison if they don't cover exactly what we cover. Again, relevant information to our PTOT and speech is that those services were added in 2014. There is a misalignment between our EPSDT rates and our state plan rates. We do have some of those providers who are delivering services to children who are now billing on that fee schedule and billing through the state plan, but we have another subset of providers who are not billing outside of the EPSDT rate. Again, there are a variety of providers who can bill for these therapy services. Hospitals can bill as outpatient. We know, again, that we have the Hospital Reimbursement Improvement Program that allows them to receive supplemental payments for services that are provided outside. They receive supplemental payments that gives them up to the average commercial rate. I think some key considerations when we look at reimbursement rates for our therapy services, definitely our state plan amendment, because again, our state plan amendment has to be approved by CMS. It does outline all of our reimbursement methodology. We would need to change our state plan amendment, for example, if we wanted to move away from 63.75% of the Kentucky Medicare fees. Kentucky-specific Medicare fee schedule and increase that, we would have to do a state plan amendment. We also would need to amend our regulations and make sure we're in compliance with all federal and state rules. We have to think about our workforce, particularly in behavioral health. And we also need to look at the fiscal impact. This study asked us to specifically look at children. We did pull in some adult therapy visits in there just for comparison, but we do know that depending on what sort of a increase may be granted, that it would have an impact on our fiscal impact. And we would also have to make system changes. We have a Medicaid management information system that houses and processes all of our claims. So we would have to modify that system in order to make any necessary changes. And I believe that's the end of my presentation. We'll be more than happy to take questions.
Pressure makes diamonds, you know. Could you go back to slide 9? What does that slide tell you?
That Kentucky is not the absolute lowest of rates for behavioral health services, nor are we the highest.
I'll ask another way. Does that slide concern you?
You know, I think, I don't know that it rises to the level of great concern because, again, this is all for all psychiatric services. Again, looking at some of those slides to know that and you've heard this before, when you see one Medicaid program, you've seen one Medicaid program. I don't know that all of the other states cover the level of benefits and the level of providers that we do. In 2014, when we began covering behavioral health services, we began covering a wide variety of providers that a lot of states don't cover that would impact what our rates look like. So, for example, if we cover LMFTs and some of the other provider types that we cover that are paid to lower rate than some of the actual psychiatrists or physicians, that would impact the way this rate looks.
I'm going to speak on behalf of all the committee members here. I don't think I'm misguided in doing this, but I think each one of us has been approached by some provider group about we're not getting enough money, enough pay. And you and I have had this conversation before. It seems like we do whack-a-mole in terms of who gets reimbursement increases or not. Dentists have been complaining for years and years. That's just one group in particular. Hospitals, I think we've taken some good steps over the last couple of years with the increased reimbursement, inpatient, outpatient. I am concerned about some of the billing, the administration side of it and what MCOs are doing, but I think at least we've got them stabilized a little bit. But there's some of the other groups that are out there, particularly this group that we're talking about here, that they said that we're not getting a reimbursement. We can't continue to do this, and this may be the best that we're ever going to look. We may move up on that chart in the future, but it's just concerned to me that we don't have a more standardized methodology of how we're going to address all these deficiencies that we know that are here other than on a reactionary basis, which we have a tendency to do. And again, that's no criticism of you. I know you got a budget you got to work with, but we got to find a better way to do this. But Representative Bentley, you have a question? Comment?
Thank you, Mr. Chairman. I have a question and a comment both. Commissioner Lee, what is EPSDT?
It's the early and periodic screening, diagnosis, and treatment benefit in the program. And
when's the last time they had a minimal increase for Medicaid?
It would depend on the provider type. We have a variety of providers that are enrolled as EPSDT. For example, some dentists are EPSDT.
How about pediatric services?
The pediatric services, I'm not sure when their rate was increased last, but it is right now $85.05 per. They have one code that they bill, and again, very difficult to determine exactly what services they are delivering and the units of services or the amount of time.
Would it be fair to say that some of them haven't had an increase in 20 years?
That may be a fair statement.
Also, on your Indiana numbers there, they're incorrect. The Indiana just had an increase of 100% of Medicare fee schedule. So you need to change that. And you being quoted as telling TAC that you supported an immediate increase in these pediatric rates. Do you still agree with that?
I don't know if that was my exact wording, but I agree with a rate increase for any Medicaid provider as long as we can find the state match to put up for that. As you know, our hospital reimbursement improvement program, the hospitals are putting up the state match for that for those benefits. And the Secretary, Friedlander, has also gone on record as saying we will pay anybody as much as we can, as long as we can find that state match. But I do support making sure that our providers have the means, the resources, and the funding to provide services to our members.
Thank you very much. Thank you for your service and your presentation. Thank you, Mr. Chairman.
Thank you, sir. Good to have you with us today. Senator Douglas.
Thank you, Mr. Chairman. Madam Commissioner, I just have one request. When we look at page 7, figure 13, and page 9, figure 17, and we talked about 2 fee schedules, could you expound on why there are 2 fee schedules, just for the benefit of people on this committee?
Yes, we have one fee schedule for non-facility providers. Those are independent providers, and another fee schedule for facilities. I'm not sure what the history is and why we had those 2 different fee schedules. I'm not sure.
I can speak a little bit to that. So Medicare also has the 2 different fee schedules, and it's basically based on the savings you would get from a facility versus from the cost for a facility versus the cost for a non-facility to deliver the services. So there's a survey about the cost, and there's just a difference between the cost based on that.
Thank you for your answer. Thank you, Mr. Chair.
Co-Chair Moser.
Thank you, Mr. Chairman, and thanks again for this presentation. This is helpful. I am going to refer back to 9 as well, slide 9, on just the behavioral health rate. And I know that we have lifted the prior authorization for behavioral health services. Can you talk a little bit about what you've seen as far as patient outcomes, or really patient outcomes is what I'm most interested in, but have you seen a large increase in participation, or that patients are getting the care that they need in a timely manner?
We haven't done an in-depth analysis of that, but we do have a report that we're reviewing to see exactly what those outcomes were. We do know that we are seeing an increase, for example, in peer support specialists, a pretty significant increase in those services. We do have prior authorizations in place for inpatient and residential, but we haven't really done an in-depth analysis, but we definitely are looking at that to make sure that we know exactly what is happening with those prior authorizations removed in the behavioral health arena, to see if it's something that we may want to look at in other areas of the Medicaid program.
Yeah, thank you. I'd be very interested in having that information and really trying to identify and understand how the peer support specialists, for one, are helping patients get into treatment, stay into treatment, and and that's kind of the behavioral health piece of all of this question. And if I may continue my question about prior authorization.
Yes, please.
Thank you. So prior authorization was removed from was it all services during the pandemic?
Yes, all services.
Right. So do you have any data that showed what the increase in cost was? And again, did we see improved patient outcomes and better, more efficient, expedited care?
We do have some preliminary information that we looked at just related to cost. We didn't see a huge significant difference in cost when the prior authorization was lifted during the beginnings of COVID. But again, I think that was a different time frame, very difficult to see, but we can definitely go back and look to see if there were any outcomes that were different. But during COVID, again, in 2020, it was such a different year, but we didn't see a significant difference in the funding or the amount of reimbursement to providers.
Okay, well, that's really good news, because obviously folks were accessing health care at a higher rate during the pandemic, just by virtue of what we were going through. So, yeah, I would love to see some in-depth information if you have that. Thank you.
I think that's a probably perfect segue into update on post-pandemic Medicaid unwinding. Thank you, Co-Chair Moser.
Which one? Oh, is it in here?
No, that's that presentation,
This one?
the one you were just on.
This is a single PBM.
And then slide 3. Our presentation wasn't aligned completely to the agenda, so we're going to hop around a little bit. So if you could go to slide 3. So as you know, public health emergency ended officially on May 11th, and since then we have been the restart of Medicaid renewals during the public health emergency. We had continuous enrollment for anyone who was covered by Medicaid, and we were not allowed to terminate those folks, with the exception of if they requested disenrollment or moved out of state. So we're playing catch up. We've gone through 7 months of renewals so far. And we're tracking a little bit as we expected. We come across some things that maybe were unexpected, such as the workload, although anticipated. We knew the workload was going to increase significantly for the Department for Community-Based Services, who does our determinations, Medicaid eligibility determinations and redeterminations. So the workload really stacked up for a while, but some of the efforts that we've made have finally, I think, paid off in terms of trying to make sure the distribution of the renewals throughout the entire unwinding period that we have to process them is helping with that workload. So this slide just kind of is a snapshot. It does not include our November renewals. We just completed those. But as you can see, as we walk through the unwinding period through October renewals, we've got a 60% approval rate. I think one thing I want to explain to you all is on the left side there where it says 83% of approvals were through ex parte. Just a reminder, what that means is that we have the ability to go out and what's called passively renew someone. There are databases, they're called trusted sources of information that we go out and automatically check. They include the Internal Revenue Service, income data, state wage data, and if we can go out and automatically verify somebody's income and other resources, then we can go ahead and approve them without the member having to do anything. So that's called a passive or ex parte renewal. It's always great when we can do that because it certainly reduces the number of potential procedural terminations. And by that, I mean, we've sent somebody a notice, we've told them that we need some information in order to complete that renewal, and they've not sent that information in. So by the time their renewal date comes up and they haven't responded, we have to terminate them. So by being able to passively renew or go through ex parte, it reduces that procedural termination rate. So as you see, the 57% on the right side for procedural reasons is that we sent out a notice to an individual and they haven't responded. We've increased the response time. We've tried to give individuals additional time to respond, especially for our long-term care and our 1915C waiver. Those are the ones the commissioner spoke about earlier. Those waivers, individuals, those renewals are a little more complex because of the level of care that we have to make a decision on, and assets and resources are taken into consideration. So we've actually given them additional time to respond to that notice so that they can pull that information together and have it available to us. Next slide. So just a snapshot to see, as we expected, the Medicaid enrollment is going down, and as a result of unwinding and processing those redeterminations. We did try to forecast at the beginning, and I think we're fairly on that forecast trend. So just looking at the slide as it goes down. Next slide. But one thing, and the reason we have qualified health plan on here is because, as the commissioner mentioned in her first presentation on qualified health plan and income, as we see individuals whose income has increased, and are no longer eligible for Medicaid, they are likely eligible for a qualified health plan and those advanced premium tax credits, those assistance, financial assistance that's available to individuals that pretty much makes that premium no cost or low cost. There are also some additional other cost sharing savings that can come or assistance that happens with that for co-pays. So we're tracking as people drop off Medicaid, trying to find out where they're going, and we're definitely watching them as they move over and could choose a qualified health plan and tracking that. One of the other things that I don't have a slide on it, but the other thing we're looking at as people come off of Medicaid is, do they have some type of third-party liability? So by that, I mean they have access to health care coverage some other way, so maybe through their employer is what we see a lot. If somebody has employer insurance and maybe they were able to obtain that during the public health emergency, as we're going through their Medicaid eligibility and their income is too high for Medicaid, but we see they have other coverage, then we feel pretty confident that they have at least some health care coverage available to them. So trying to track those as well. A lot of folks are always interested in the home and community-based waivers and what we did during the public health emergency to support our members and providers. We had lots of flexibilities. We increased rates. The legislature in the last budget had required us to utilize some funds for increased rates during this period of time. What we're happy to say is that a lot of those flexibilities are not going away. We're going to implement them permanently, including rate increases. What we had to do in order to make that happen is by November 11th, so they had a different date than the rest of the unwinding period for our flexibilities. They had a different date. So on November 11th, we had to file all 6 of our waivers. We have 6. We had to amend them and put the flexibilities, including the rate changes in those waivers, and file them with CMS and submit them to CMS. So we have done that. They're all pending review and approval, but while they're pending, those flexibilities remain in place. So we're able to continue to pay those higher rates, and we're able to maintain those flexibilities during this period of time. Yep, that's the last slide on unwinding.
Let me ask you about the 56, 57% that's dropped for procedural reasons, and I certainly understand that. It's tough to get people to respond to anything these days, but is there an additional plan to try to reach out to those folks, or what's a continuing process, if there is one?
Sure. Thank you for that question. So just to explain our outreach plan, prior to somebody terminating the state, we have a team that has been calling those folks at least 3 times prior to their termination date. And then if they're a managed care member, they also attempt to reach them prior to that termination date, that renewal date. We also try to contact them by text and email if we have that contact information on file. Post termination, they remain on a list to call and still try to reach. We also we're tracking reinstatements. So one of our flexibilities, if somebody does respond within 90 days of their termination and they're able to provide us the verification that we need, then we can automatically reinstate them back to their termination date during that 90-day period. So there's no gap in coverage. And we've been doing a lot of communication with providers and our other stakeholders around this, so that if somebody walks in and they just were terminated, we've got a lot of information out there they can hand to the member and understand that if it's in that 90-day period, we could probably get them back in if they're eligible. They have to be eligible, but if we can get them back in, then we're able to reinstate them. But we are tracking reinstatement numbers. We're averaging about, depending on the month, about 5,500 come back in through reinstatement. And doing up to 90 days, the managed care organizations are also able to still go out and try to reach those individuals and assist them with what they need to do.
Have they been an active participant? I mean, obviously they got a vested interest in this thing because if they don't have the Medicaid recipients, they're not getting their fees. So
Yes.
are they committing resources to it to address this?
They are, and in fact, several of them have created new call centers, call teams, contact teams to reach out to members, and they are also allowed to help work with the member on understanding what is needed. We train them on what it is, what does it mean to, ask for some certain piece of information. So the managed care organizations and their teams can outreach and help that member understand what they need to do and get them connected with folks that can help them.
All right, good, thank you. Senator Berg, you have a question?
Yes, thank you, and thank you, Mr. Chairman. Somewhere earlier today, we had a slide that, at income of 20,000 something or less, you're eligible, and then you make $1 more and you're no longer eligible. Do we know per individual for those people that get cut off at that $1, what the average cost of them being able to get comparable coverage in the marketplace costs that person?
Well, as I said, so if they move over to a qualified health plan, up to 300%, I can't remember the number, but up to a certain percentage of the federal poverty level above Medicaid, they can access that advanced premium tax credit. So that can make the premium zero. And it could potentially also, because of financial assistance that's available for cost sharing and copays, it could also help them with that. So it's really it's hard to know. It depends. I mean, we have information that could say, based on the federal poverty level percentage, what somebody is likely to pay, what's the average premium. We do have that information. I don't have it here available for me, but happy to get it to you.
Would it be possible just to let me know for, what the average cost of a comparable plan on the market would be? Just so I have an understanding of what we're asking these people to pick up on their own.
Yeah.
Thank you.
I think what I would like to add to that, I think I understand what you're asking, but Medicaid covers so many things that private insurance does not or commercial insurance does not. It's going to be a little bit difficult to get that comparable, but we could definitely get an average cost of a commercial plan.
Representative Duval, you have a question, comment?
Commissioner Lee, you had said that we had a 6% uninsured rate in Kentucky. Is that correct?
Yes, the last time I checked, it was 6%.
What were those rates 10, 20 years ago? Do you have that information?
Prior to 2014, we had a very high population that was uninsured in our adult population. Our children's health, we've always had lower than average in children, so we look at the population, but it was a significant amount prior to 2014. I don't have that information, but we're more than happy to go back and look at that for you.
Last question on this subject from Representative Whitten.
Thank you, Mr. Chairman. Thank you, Commissioner Lee. I had a question regarding in the Public Assistance Program, the SNAP program. Are there any limitations, or who determines the limitations on how the SNAP funds are used?
I'm looking for my colleagues in the Department for Community-Based Services. I don't have that information with me. That program is overseen by the Department for Community-Based Services, but we can definitely take that question back and get you an answer.
Do you know if there are limitations to what types of food products they can purchase?
I'm not sure if there's a limitation or anything related to the food.
Mr. Chair, I would argue that that's important, that we need to take a look at that. That if we are, the name of the service is Supplemental Nutrition Assistance Program. And if there are no nutritional guidelines that those funds can be used for, I think that we're doing a disservice to that community. So I would recommend that we take a look at that.
Thank you. Let's move on to our next agenda item, which is the pharmacy benefit manager situation. And again, I know you folks have reported to us previously on this and given us kind of gross numbers. You might recant for the committee again as to how much we save, both state and federal. And the singular question I have regarding this matter is, giving those savings, which were quite substantial, what was a single PBM able to do that 6 PBMs could not, would not, did not do?
Absolutely, Senator. So just to recap from I've got to use my glasses on this one, for our presentation.
It's getting serious, yeah.
It is. For our presentation in September to the committee, as we reported in calendar year 2021, we saw a combined federal and state funds of $172.5 million. And in calendar year 2022, it was $110.2 million. That's a combined federal and state. As we evaluate what has happened since Senate Bill 50 and the changes that we've made to the pharmacy benefit program, sorry, my computer. I know. I think one thing that's difficult, and I think we testified to this in September, is really the pharmacy benefit changes, the drug mix. There are always emerging and new drugs that are very costly. Insulin is a good example of a drug that was very expensive and then came back down. Thank you, Representative Bentley. But because there are new emerging drugs, it's hard to take a snapshot of one year and compare it to another year because the drugs change. The great thing about Senate Bill 50 that also helped with what we implemented was the single preferred drug list across the MCOs, because prior to that, they were able to have their own, each MCO could have had their own preferred drug list. They primarily preferred generics because generics are generally cheaper. But for us, from the state Medicaid agency and a fee-for-service, the brand name drugs are always cheaper for us because we can get a significant rebate. And by rebate, I mean that the manufacturer reduces the cost for a state Medicaid agency to make that drug more affordable. So by leveraging brand drugs with a single preferred drug list across all managed care, we now have seen significant increases in our rebates. And that has offset what we also see as a growing cost to pharmacy because of the cost of drugs. It's a national thing. It's not specific to Kentucky. All states are seeing it. I'm sure everyone in the commercial and private sectors are seeing it. The pharmacy costs are going up. So we fortunately can leverage the rebates to and maximize them as a way to offset the increasing cost to us. I think intrinsically it has created a lot of reduction in administrative burden. I think if you ask providers, I hope what they say is that using one PBM is a lot administratively easier than to go across 6 plans and understand what each plan's preferred drug list is and what their prior authorization processes are. So I think it really, in that sense, has helped the providers. And then lastly, transparency is another, I think, intrinsic benefit from that is everyone can see our contract with our pharmacy benefit manager. It's a public document. Everybody can see it. It's out there and available. You can see exactly how much we're paying our PBM, our pharmacy benefit manager. You can see in our regulations what our reimbursement methodology is so that everybody knows and understands and has full transparency on how we pay for the drugs. So, I think it's that combination of different measures or tools that has led to what we're seeing as, the benefit to Senate Bill 50.
Well, as Gomer Pyle would say, golly. You know, I would suspect that the other PBMs could have employed the same strategy. And that's why they didn't. I think warrants some review and some discussion. But, you know, it's just something maybe that our auditor's office should take a look at. You know, this is significant savings over a 2-year period for us. 50 million. We go back, total 285 million for state and federal. We go back 5 years. We're talking about over $1 billion. Should we go back and look back on what the PBMs did, and if they didn't do it appropriately, claw back the money that we gave them?
Sure. So in terms of clawback, the tool that's available to us is called a medical loss ratio. And and Kentucky has a fairly stringent medical loss ratio. And by that, I mean, we set our medical loss ratio at 90%. So MCOs, managed care organizations, are required to spend at least 90%, so 90 cents of every dollar, on healthcare services. If they don't, that's when we'll claw back. So after a certain run-out period, we'll go back and look at a calendar year and see, did they meet that 90%? And if they're below that, then we'll claw back money. Most of that's federal money.
Yeah, that's okay. We'd like to save federal government money too.
Yeah. But the other kind of nuance to it, it's across the entire program. So we don't have an MLR for pharmacy. We don't have an MLR
that's
for
the
physician.
point I wanted to make. Is
yeah.
It's more than a coincidence to me that this whole thing with our independent pharmacists and the problem with PBMs happened about the same time that we adjusted our medical loss ratio from 85 to 90%. And at that time, our budget was $10 billion. You do the math, that means a loss of profit of those folks between $250 and $500 million, which is the same amount that we're now realizing by single source PBM. So I'm suspecting that I guess prescription drugs are probably about 15% of our Medicaid budget. Is that about right?
I have to look to Steve on that
Well,
one.
take my word for it.
Say
It's
that.
around 15%.
Around, yeah.
So, yeah, that's in their medical loss ratio, but we can never verify that 15%, 90% of that actually with the prescription drugs, because they're paying themselves. That 15% is within the 90%, which they're paying themselves. But we have no validation that it went for what it was supposed to go for. And I think it made up for that lost profit margin that occurred when we went from the 85% to 90% medical loss ratio. So the final word I have, I think we need to take a look at this going backward and possibly ask for some reimbursement, clawback.
So it's across the 90% across the program. We can't just look at pharmacy. We have to look across all the services in meeting the 90%. We can't hold them just to 90% for pharmacy or 90% for physician
That's okay.
services.
What I suggest is an RFP from groups to take a look at it. We'll do it on a percentage basis, and everybody benefits from this. So I would strongly recommend that. Senator Berger?
Yeah, and I would like to suggest that if this holds up in the future, we could require that not only, that 90% is covered for pharmacy as well, couldn't we?
I would have to actually take that back to our actuary to see that how we calculate the medical loss ratio is based on what's the Centers for Medicare and Medicaid Services. There are federal regulations we have to follow on how we calculate that. So I don't know if we can just put an MLR to pharmacy, but we're certainly happy to take that back.
Well, we need to. And last comment I'd make about this is appreciate your comment about reducing administrative burden and going to one single. And again, prescription drugs represents about 15% of the Medicaid budget. That's 85% that goes to medical. Maybe if we went to fewer MCOs, we'd realize a comparable savings in administrative cost and burden, and also easier to track whether they're paying what should be paid. So, any other questions, comments? We have one additional agenda item. Yes. Representative Bentley.
Meredith, you love win-win situations. This is a win-win.
Yes, it is.
That's right.
Representative Callaway.
Thank you, Chairman. Thank you for the thorough presentation. I just have a quick question, and I'm sure there are plenty who know the answer to this in the room, but if you don't mind educating me. So when you talk about the single preferred drug list, and you talk about the benefits for the manufacturers of the brand name drugs, and they give rebates, who is eligible to receive those rebates? I mean, across the board, who are those rebates available for? Because what I'm trying to figure out is why a manufacturer is going to keep a product overpriced and then offer rebates instead of bringing their price down to be more comparable to the generic cost. So if you could just educate me a little bit about that.
Sure. So the way it's required at the federal level for rebates to a state Medicaid agency, what it does is it offsets our expenditures. So it has to come to us to offset expenditures. Does that help?
So simply state agencies are eligible for that rebate.
Not necessarily.
MCOs, well, it depends on what you're talking about. Like
Co-Chair Moser and I are chomping at the bit to speak on this, but go ahead. Feel free.
Well, yeah, I mean, this is a bigger conversation. And I was actually kind of thinking about the MLR and the contractual issues with the MCOs and how the PBMs are kind of rolled into that because the MCOs actually contract with the PBMs. So, I mean, I think is that a simpler way to
Well, that's how it used to be.
Yes, right. No,
Yep.
I know we changed that. So I think when we're talking about pharmacy costs, the 340B program is probably what limits us from actually having transparency around this issue. I mean, I know that there are some negotiated rates that happen with the manufacturer, and it's passed on to facilities. It used to be individuals who were included in the 340B, and this has gotten, in my opinion, out of hand. I think it's expanded beyond the original intent of the program. And I think it's really hard for us to see, and by us, I say the general public, to really see the benefit of those programs. I mean, I hear that the spread pricing, if you will, between the manufacturer's price and the wholesale price, I guess, is going to charity, but we don't really see that, or it's so I have a lot of questions about that program and pharmacy benefits just outside of the normal PBMs. So I don't know if you have any comments, and it probably muddies the water more than it helps because it's a big program.
It is a big program, and but the PBM situation is certainly one that's gotten out of hands. And I think we'll see PBM legislation during this next session, so we'll have an opportunity to discuss this in a whole lot more detail than we are today. But any other questions, comments? If not, we've got one other agenda item. I promise you won't take long, and Steve, appreciate your patience with us here. Just want to give a 10,000-foot view of this, just so people understand the growth of the Medicaid program over the years. I know you made this presentation before to Budget Review Subcommittee, but just want the committee to understand the scope of the Medicaid program financially. So please proceed.
Thank you. So what I've provided you all here today is a table just shows you our spend from state fiscal year 20 through state fiscal year 23. And I broke it out by how much we paid in managed care capitations, directed payments. Those are the directed payments are the things that we talked about earlier, the hospital rate improvement program. We also have an ambulance provider assessment program where we're helping fund some supplemental payments to ambulance providers. And then we also have the university directed payment programs as well. So those are in the directed payment lines. Non-emergency transportation capitation, that's the NEMT, what we call NEMT. That is to where we're paying a capitation amount through the Kentucky Transportation Cabinet to brokers to provide transportation to and from appointments, things like that. Nursing facility payments, 1915C waiver payments, and then all other fee-for-service payments. And then I listed out the drug rebates that we have collected year over year. As you can see, we have the spend has increased from 2020 of $11.8 billion to 2023 of $16.6 billion. And you can see across there, the majority of that is through the managed care capitations as well as the directed payments. The managed care capitation, the reason for that growth was what Veronica mentioned earlier about the maintenance of effort. During the pandemic, we had to maintain the eligibles, so you're paying more eligibles, and as you're paying that, healthcare cost is increasing, and pharmacy cost is increasing, and so therefore the capitation payments increase as well. So that's why you see a big jump there. And from 22 to 23, you can see about a 10%. It's about a 10% jump from one year to the next when you compare 22 to 23 on just the managed care line. When you look at overall, you're looking about 11.3% increase. I will say, I'll point out that the 1915C waivers, the reason why it jumped up so much, there was about a 34% increase from last year to this year, is due to House Bill 1 language, where it asked us to increase the rates by 10% for 5 of the 6 waivers across the board. But also there's another piece in that legislation that said 50% increase for residential stays. So that is driving what drove that increase in spend. The other thing is the drug rebates, like Veronica just said. Yes, we've increased our drug rebates, but I want to make sure you understand there's an increase on the cost side too, in order to gather those rebates. I also broke down federal and state general funds and state restricted funds down at the bottom. You can see that our state general funds have remained consistent pretty much across all 4 years. The increase, the biggest increase in state funds was the restricted funds, and that is from the directed payments, where they're paying the state match of that. So that's why you see that big jump there. The federal funds is what is being increased. Now, I know that you asked for 24 through 26. We're still finalizing that with the governor's office, and we're going to continue to work with that. We'll be in full support of that when that's released. But what I can tell you is in 26, we have about $395 million state general fund request. And that's just to do what we call continuation of services. That is the cost of doing business, what we're doing today, how much it's going to cost in 2026. I just mentioned the 10% rate increases. That's part of that. Because we're going to do another 10%. If you remember, we did another 10% in 24, is what House Bill 1 asked for. So those concade on one another, and it's a price tag to it. And I believe you all understood that because you put in the language that it was your intent to fund that with general funds for moving forward. The other things that's driving it was there's a decrease in our federal match rate. During COVID, we got an additional 6.2% FMAP. When those funds go away, we got to replace them with something, and what we're going to have to replace it with is the state funds. So that's driving it as well. And then the last thing, as I've already mentioned it, don't have to tell you all, healthcare costs is increasing by the hour, pretty much it seems like. And we're having high-cost drugs are being introduced daily, if not weekly. And those drugs are very costly at times. And so those are the things that's driving that ask for the $395 in 26. We did not ask for any additional general funds in 24 or 25, which current year or 25. We have cash that we're going to use with those restricted funds. We should be able to make it through that, but it's the 26. I just don't want you all to be blindsided, but because when you see it, it's a big sticker shock. It was to me, but.
Well, that's why you're here today, because I want people to understand that this is presented in the context. We've got a budget year,
Yep.
and got to fit it all together somewhere or another. But appreciate that. No surprises there. One real quick question, Commissioner Lee, just because it's been out there for some time. So we had a discussion several weeks ago about sepsis and reimbursement, and apparently a letter was sent out that we would not be reimbursing for sepsis level 2, but we would do 3. But I understand we backed up on that.
Yes, we are going to be moving to sepsis 3, but not until 2025, I believe. So there will be more to come on that.
We're also, there's going to be a work group with the hospitals, and that was requested by the Hospital Technical Advisory Committee, and we're full support of that. So we're going to be working with that group over the next several months to make sure everyone understands what the impact to that is.
With that instance, a letter was sent out saying we're not going to reimburse 2, but we're going to do 3. Could we do a letter saying we're backing up on that? There's a task force, just so everybody knows that.
Yes, we can definitely do that. We have had some, I think, verbal communications, but we'll definitely make sure that a letter gets out. It hadn't been drafted already.
Appreciate that.
Chairman Meredith, if I may say one more comment too on why the 395, the increase is also. Veronica mentioned that we are going through redeterminations, and we're seeing our enrollment to go down, but those who are leaving are low utilizers. Those that are leaving are not using the program as much, which is probably why they're not responding sometimes. So you're going to see the same level of cost almost being spread out over a lower number of people, which is causing the increase there as well on rate side.
All right. Duly noted. Anything else today for the good of the cause? Again, Commissioner Lee, appreciate you and people being available to us, gave us valuable information. I'd encourage committee members, again, take this home with you, review it as we prepare for the next legislative session. If there's no other business come before this committee, we stand adjourned. I wish everybody a very Merry Christmas, Happy New Year. See you January 2nd. Thank you.